All right, chapter 43, the nursing care of male patients with genital urinary disorders. Excuse me. Learning outcomes. We're going to explain the pathophysiology associated with each male genital urinary and reproductive disorder discussed in this chapter. Describe the etiology, signs and symptoms, and treatment of prostate disorders. Plan nursing care for men with genital urinary and reproductive disorders. And describe disorders of the testicles. I don't know what's in there. List selective physical and emotional causes for erectile dysfunction. Discuss the nurse's role in helping men cope with loss of sexual dysfunction. Identify disorders of the male reproductive system that interfere with fertility. And list treatment options available for male infertility. All right, so for the prostate disorders, we have prostatitis, which is just an inflammation of the prostate. And we have BPH, which is benign prostatic hyperplasia. And then we also have prostate cancer. Now, prostatitis is an acute bacterial prostatitis. It's short term. It doesn't last very long. But there is chronic bacterial bronchitis, but it's very rare. Eventually, it can cause pelvic pain syndrome. Usually, though, it can be asymptomatic. Your signs and symptoms are pain, urgency, frequency, dysuria, urine retention, and fever and chills. Our diagnostic test is often there's a DRE done, a digital rectal exam, a urine culture, and cystoscopy. Our interventions are antibiotics, anti-inflammatory agents, stool softeners, sitz bath, prostatic massage, dietary changes, and surgery. Nursing diagnosis is urinary retention, deficit knowledge about the cause, treatment, and prevention of prostatitis, and acute pain. Okay, BPH is what we see a lot of. It's an increase in number of cells, just general enlargement of the prostate, or as time goes, as the prostate ages, it atrophies and becomes larger. Signs and symptoms are urinary retention, dribbling, nocturia, dribbling as in urine coming out of the penis dribbles. It doesn't have a forceful flow or any strength behind the flow. Nocturia means frequent urination during the nighttime. Dysuria is painful urination, and of course, urgency. Diagnosis again is a digital rectal exam, a blood urea nitrogen and creatinine test, because with the backflow of urine, it could start causing problems with the kidneys. Prostate-specific antigen to rule out cancer, and a urodynamic flow studies and transrectal ultrasound and a cystoscopy are all diagnostics. All right, so symptom control, we have catheterization. Oftentimes obstruction. There are a few reasons that justify catheters. One of them is obstruction, and typically obstruction is from scar tissue and or from BPH. So often you'll see more men with catheters than women because of the prostate causing a blockage. Also, fluids and antibiotics. Interventions, we want to keep a watchful, waiting eye because at any time it could constrict the ureter and then cause the bladder to become distended and unable to urinate. So we have to be on our toes about that, and they don't really understand they do. They know that unless they've had prior, what's the word I'm looking for? Experience of having urine trapped in their bladder and unable to urinate, they may not know what's causing this or what they're going through. So they'll come to the ER in severe pain, abdominal pain, and you have to ask, hey, when was the last time you urinated? And whoa, they didn't even realize, that's what it is. So by the way, putting in a catheter of a person who has BPH or blocked urethra is very difficult. And it can be very painful as well. So just give you a heads up on that. Not a good time. There is interventions for this. We have hormone blockers, transurethral microwave therapy, transurethral needle ablation, and surgery. The surgery usually entails a TURP, which is a transurethral resection of the prostate, where they basically put a scope down the penis and chip away at the prostate to give it an opening for the urethra. Kind of cool. Painful. Has a little bit of a recovery time because of the blood content. It can potentially block urine if we don't, you know, keep it flowing, I guess you could say. All right, so prostatectomy is when you remove the prostate or at least partial prostate. It's usually in the perineal area that they do the prostate, or they could do it on top during the retropubic, but usually the best way is in the perineal space. Prostate surgery, the nursing diagnosis: risk for bleeding, acute pain, urge, urinary incontinence, deficient knowledge, and anxiety. Um, Typically, men have a problem with prostate surgery because of their inability to have an erection afterwards is a concern. And then they'd have to go into to, um, discussing alternatives that can be done now. Post-op nursing diagnosis: risk for bleeding. We want to monitor urinary output and bleeding, encourage fluids, teach the patient to avoid constipation, lifting, and insets. Acute pain related to bladder spasms: monitor your pain, irrigate the catheter as ordered. Remember, I told you one of the reasons that it's such a high risk to have, a TURP is because of all the bleeding and clots that come through. The catheter can block urine as well. We're going to need to administer analgesics and antispasmodics, and teach relaxation and deep breathing. Urge urinary incontinence: teach Kegel exercises. Yes, men can do Kegel exercises too, and should. Offer condom catheters or pads. Encourage to continue fluids, and discuss prolonged incontinence with the physician. All right, so postoperative nursing diagnosis: deficient knowledge. We want to teach to avoid for 6 weeks any heavy lifting, stairs, driving, strenuous exercise, straining, sexual activity, aspirin, and NSAIDs. Report signs and symptoms of urinary tract infections, and report an increase in bleeding. This is the bladder irrigation. I'm going to be honest with you guys. One of my questions on the NCLEX was I had to put step by step how to set up a bladder irrigation. I've never done it before. I work in OB. But I had seen it, but I'd never actually done it. And luckily, yeah, I think I got it right because they stopped asking me questions in that area. But it was pretty intimidating. These are huge 5,000 ml bags of saline, and they're basically, you can do it intermittently where you're flushing the bladder, and to make sure that you're diluting any blood clots that might be coming in. Anxiety related to sexual function: explain retrograde ejaculation and talk with the physician if erectile dysfunction does occur. So for prostate cancer, risk factors are over the age of 65, high testosterone, high fat diet, family history, and occupational exposures. Signs and symptoms are rare in early stages. They usually don't have any signs. But later stages, there'll be urinary obstruction, hematuria, and urinary retention. Advanced stages are bone pain, anemia, weakness, and weight loss. Your diagnostic test is your digital rectal exam, a PSA or ISO PSA, transurethral ultrasounds with a biopsy, and bone scan. Your therapeutic interventions is early stages is testosterone suppressing medications. Later stages is a TERP or open prostatectomy and radiation therapy. Mastatic is orchiotomy or estrogen therapy, and then chemotherapy and radiation and radical prostatectomy are likely going to be happening. All right, so penile disorders is your Peyronie disease, which is a curved penis, which there are fibrous bands that make it curved. Priapism is prolonged painful erection. Typically happens with the inappropriate use of Viagra or penile stimulants. Also, sickle cell anemia, it can also happen. So that's something to be aware of. Very painful too. Yes, we do have to stick a needle in the head of the penis and um, release the blood. hmm Phimosis or paraphimosis is foreskin is not retractable. Um, that's pretty painful as well. All right, so cancer of the penis, risk factors are uncircumcision and HPV. Therapeutic interventions are surgery, radiation, and chemotherapy. So, like a lot of people, that's kind of interesting when they say like uncircumcision puts you at a higher risk for penile cancer. It also puts you at higher risk for damage, pain and infection as well. So, yes, it's cultural, the choice to circumcise or uncircumcise, but it's also, there is some medical components to it as well. Testicular disorders, your cryptorchidism is undistended testes. Sometimes young boys are born with the testicles still in the inguinal sac, up high, basically. And they might drop on their own or they may not. We may have to surgically go in and release them down. Hydrocele is fluid in the scrotal sac. It could, oftentimes when the testes have not descended, there will be a hydrocele there as well. So we will have to get rid of the hydrocele in order for the testes to descend. And a varicocele is when there's varicose veins of the scrotum. Epididymis is inflammation or an infection, and orchitis is testicular inflammation or infection. Testicular cancer is cryptorchidism. So your risk factors is if you were born with your testicles not distended, you're at a higher risk for developing testicular cancer later in life. Also, if you've had a family history, or there is, okay, so DES used by the mother during pregnancy is back in the 70s and 80s, I think it was more like 70s, they had an anti-nausea medication that they were giving out to women during pregnancy that was supposed to be completely safe, and turns out it wasn't. It also causes ovarian cancer in girls. Like even my mom, she used DES during pregnancy. But um, no, no ovarian cancer, but it has been known to be a risk factor. Being Caucasian also increases your risk for testicular cancer, and high socioeconomic status for some reason. Signs and symptoms, early stages, painless lumps and swelling. Late stages are symptoms of metastasis. I hear it's lower back pain and a sense of fullness, basically. Diagnostic test is ultrasound, chest x-ray, blood for tumor markers, and biopsy and staging. Therapeutic interventions is surgery, radiation, and chemotherapy. That's kind of that's the therapeutic, and I mean that's basically all we have for cancer. Is just burn it, cut it, or try to get it out chemically. That's it. It's all we got. Die with dignity. Those are the four options that you have with cancer. It's terrible. Um, Testicular cancer nursing care. We want to teach testicular self-exam, provide emotional support, discuss sperm bank deposits, and offer cancer support group. Remember, it isn't the fact that you won't be able to produce sperm after removing one of the testicles or the affected testicle. It's the damage that the chemotherapy does to the sperm, to the testicle, even the one remaining, that could cause a problem with fertility. So it is recommended that before chemotherapy starts, you do decide to bank sperm if you want to have children in the future. Because this testicular cancer, it happens to young men. It doesn't really happen to older men as much. Just testicular and also penile cancer. These are young men affiliate. I mean, it usually happens with younger men or around puberty. Vasectomy is an interruption of the vas deferens. That's the tube that carries um, semen from the prostate to the urethra, provides permanent birth control, is effective about 3 months following surgery. So, can you get somebody pregnant after having a vasectomy? Yes, for up to 3 months and actually up to a year. You're supposed to go for a follow up a year later to verify. So, here you go. This is supposed to be a very simple procedure. It's usually done in an office setting. It's done with a local anesthesia. They don't even have to be put out for, um, you know, anesthesia. Usually, an anti-anxiety medication is all they get put out for, and it's like a little incision on the side of the scrotal sac. And yeah, they're back home by that evening. Whereas sterilization for women is a huge procedure. It's pretty, you got to be put out. It's a laparoscopic procedure. It takes about a day to recover. It's usually an in and out procedure though, but they have to go to a surgical suite, surgical center. You have to be put under anesthesia. Erectile dysfunction is a problem obtaining or maintaining erection. Pathophysiological and etiology is physical. You're going to have circulation, nerve supply, hormone balance. Anything and everything can cause erectile dysfunction. Stress. There may not even be anything physically wrong, and you're still having erectile dysfunction. It could be fatigue, right? Illness. Alcohol is another one. Drugs. You may be having a bad effect with, a bad side effect from one of your antihypertensive medications. You may also, antidepressants can also cause erectile dysfunction. Lots and lots and lots of things can cause erectile dysfunction. You want to get a history, figure out what medications you're on, um, maybe a diet, maybe you're taking supplements, um, maybe you're taking steroids and don't realize it. Those can also cause erectile dysfunction. Blood tests, you want to get glucose because diabetes can cause erectile dysfunction. I mean, just lots and lots and lots of things. Testosterone levels, evaluation of circulation, and psychosocial evaluation as well. Your therapeutic interventions, any medication changes, we might need to give you oral medications like Viagra or Cialis, hormone therapy, and herbal remedies. Um, Medication, there's injections and transurethral devices. So there's implants as well. Those are quite interesting. I had never, well, I had an experience with a penile implant um, in surgery. I was I was in surgery to learn how to scrub tack. Um, I think I was a word clerk, and a man coming in for I forget what it was. I think it was a hemorrhoidectomy. He had a penile implant, and yeah, I was pretty much caught off guard by it because um, yeah, it. I don't know if they're better now than they were then because this was about I don't know 25 years, 20 years ago or so. But they stay continuously erect, and that's kind of awkward. So I think they're better. I think they have better ways of doing these mechanical things now than they used to. But yeah, that was my implant experience. It was quite awkward. Yep, this is what it looks like. Okay, so now they have the balloon. There's some that, like I said, you could, I guess it's like bends at will. Um, this fills up with a balloon pump on the side, I guess. A nursing diagnosis for erectile dysfunction is sexual dysfunction. Infertility is caused by causes can be pretesticular, meaning um, is is there damage being done to the sperm in the testicles? Um, are you are they too hot? Right? Remember, somebody said it's best to wear boxers instead of briefs. Well, there is something to be said for that. The warmer testicles are, the hotter the sperm gets, the more damage is caused. So yeah, maybe not wearing anything binding or keeping the testicles too close to the body may be helpful in fertility. Also, variceals are idiopathic reasons, and post-testicular surgery also there's infertility. All right, so what are we going to do? We're going to see sexual practices. Oftentimes, infertility is happening because sex is not happening enough. Um, if you're just having sex during, this is what I was told by an OB/GYN, and I never had any problems with fertility, but it is such a common issue right now. Um, but the issue is that I had my children when I was 19, 20 and 22 years old. Let's just say, me and my husband it was less than 5 years of marriage. We were young. We didn't have anything else to do but sex. So, of course, sex is happening pretty often. We didn't even think about it. It wasn't exactly accidental, but it wasn't planned either. That's how pregnancy happened then. If I were to turn around and expect the same circumstances to happen now or even in the last 10 years, that's impossible. I'm exhausted. I'm not having sex every day. I'm not even having sex. You know what I'm saying? It's a different circumstance. We have lots of things to do. We have our careers. We have our kids, our almost older kids. We're traveling. We're doing so many different things now. So it would have a huge impact on um, fertility. So basically, what it is semen does not just impregnate. Semen makes the vaginal canal more hospitable for sperm to survive. So if you are just having sex during your ovulation time, you're only those sperm are not going to survive the vaginal canal to get to an egg because the vagina is not a hospitable environment for the sperm. It's very acidic, and sperm is very the opposite. So you have to have sex more than once. I know it only takes one time. Blah, blah, if you're young, okay. But The older you get, the more unhospitable the vagina becomes. Um, in a lot of cases, especially in infertility cases. So please just like they're going to look at your sexual practice. Are you having sex often enough? And maybe education needs to be brought to you as to why sex needs to be happening more often if you want to be getting pregnant. Lifestyle practices as well, occupation, you for various reasons, may not be able to get pregnant just because of, I don't know, environmental issues at your workplace. Maybe you're exposed to things that decrease your sperm count or whatever. Medical, surgical history, physical exam, and semen analysis. Therapeutic interventions, we're going to changes in lifestyle practices, surgery if indicated, and in vitro procedures. Okay, review questions. The nurse is caring for a male client with complaints of frequency urgency and feeling that he cannot empty his bladder. The nurse anticipates preparing the client for which procedure? A blood test for PSA, excuse me, a blood test for HCG, a digital rectal exam of the prostate, or a urodynamic flow study. I would say number 3 would be the least, it sounds more invasive, but it would be the most beneficial for this patient. A client has a diagnosis of BPH and asks what the doctor means by watchful waiting. Which response by the nurse is best? The doctor will have you visit once a month to check your prostate. The doctor will want you to report back on your symptoms regularly to monitor your condition. 3, you don't have anything wrong with your prostate yet, but you will need to get it checked out often. I'm not really sure what he means by that. I'll have him come back and talk to you. The doctor will want you to report back your symptoms regularly and monitor your condition. I think it's number 2. Yeah. Which assessment findings are expected in a man diagnosed with variceles? Select all that apply. A varicele is varicose veins on the scrotum. So I would say the scrotum will be tender and red. The scrotum feels like a bag of worms. Painless lump is noted on testicles. No. Testicle is extremely tender. Not necessarily. Symptoms are worse when standing. I'm going to go with 1, 2, and maybe 5. Oh, 2 and 5. Good. A 28-year-old male reports to the nurse that he has been having trouble maintaining an erection. Which assessment finding should the nurse further explore? 1, his father has prostate cancer at 70. Geez, that's kind of jumping the gun. 2, he has had multiple sexual partners over the last 5 years. 3, he drinks about a case of beer over each weekend. Or 4, he smokes 2 packs of cigarettes per day. Now, normally you would say 4 because smoking's always bad. But when it comes to erectile dysfunction, I'm telling you right now, it's the beer. Okay? Um, that is correlates. A client has returned from transurethral prostatectomy with a continuous bladder irrigation. Which of the following assessment findings should the licensed practical LVN nurse report to the registered nurse? A blood pressure of 135/80 with a pulse of 88. Respirations are 20 and temp is 98. Client states his pain is a 6 out of 10. The catheter bag contains bright red, cherry red urine. The catheter tubing is secured to the abdomen. I'm going to say this is kind of normal. Uh, the bright cherry red urine, from what I recall, it's at least light pink. I know that, but I think it's pretty normal. Um, I think it's the client has returned from. It's post-op, immediate post-op. So I'm going to go with the state 6 out of 10 pain, number 2. Yeah.